Welcome back to part 3 of the postpartum years as we cover more tongue ties and how it impacts mom and the postpartum body.
So, moving forward into procedural risks. So, there are different risks um, where, if they, aside from like the kids where they shouldn't be doing this, the poor outcomes, like with that one baby, had that mom jumped into having a tongue tie revision, um, that baby could have had a very poor outcome because she could have developed some aversion to just
Any
food in
food,
general. Yeah.
including solids, which he just was conquering and doing great with. So, like, don't.
Yeah. Another risk is the tongue movement patterns don't change. I'm going to get into that a little bit more later on in this chat. But if that tie wasn't the issue for the tongue pattern in the first place, yeah, the tongue pattern isn't going to change. And if there's a ton of other stuff going on, the tongue pattern isn't going to change. If the baby is months and months and months old, and that's their pattern, they need to relearn a new pattern. So they would need to go through some therapy to learn a new pattern. And then also parents who have a low follow through with active wound management. And this is another thing the Academy of Breastfeeding Medicine had said, and we've both seen. Every single practitioner who does tongue tie releases has their own protocol as
Yep.
to, you need to do this, you need to do this, you need to do this, you need to do this.
And you need to do it for this longer. You need to do it for that longer. I'll do follow-up checks at this point and that point, or only at this point, or no follow-up, or no protocol. Yeah.
Yeah, it's somewhere between nothing and, oh my God, you're torturing that baby.
Uh-huh. Yeah.
So the low follow through with active wound management, y- yeah, there's so much to say there, but um, eh, to me that throws the blame on the parents, really, which I'm sure sometimes it is, but um,
Who likes hurting their kid
I
repeatedly?
know, I know.
And like we were talking about, like, even if it's not the actual pain of touching or moving the tongue in that wound, but it's just inexperienced hands going into a mouth aggressively and pissing the baby off because,
Hmm.
like, they're getting, like, what the hell? Like,
Yeah,
I didn't know that was coming. Whoa. Like, that's gonna create this like negative feedback loop between the parents and that infant. So it's like, even if they're doing it right, it
right.
doesn't feel good.
No, no. And being the therapist that I am, I'm like, there are so many different reflexes that we could tap into that the baby, it just seems like play rather than
Uh-huh.
actual,
Well,
torture.
hey, anybody out there, if you want to do research on teaching infants functional skills or using reflexes to prevent reattachment instead of active wound management stretches, reach out. Hopefully, you're in the DMV area. Mary Ellen and I would love to work with you. Let's do this. Let's get the research.
All right. So again, moving forward, um, post-surgically, research shows that there's a decrease in nipple pain when there have been tongue and lip tie releases, and also that breastfeeding efficiency is improved, which, I'm glad it was research, but to me, it's almost kind of like, duh.
In my clinical experience, just recently, one of my colleagues that saw a patient inpatient, they did a weighted feed. Baby was 4 days old, was still in the hospital due to jaundice levels. So poor feeding sometimes causes high bilirubin levels and needs babies to go under phototherapy. Sometimes it's not feeding related though. And so she scheduled an outpatient with this family, and she was going to like reaffirm and tell this family, like, you really need to get this cut. This really needs to get cut. So mom's milk was in. She was pumping 60 mLs on each side, day 4 postpartum, and baby transferred 15 mLs in 30 minutes. Day 4 postpartum. So they came back in for an appointment day 8 postpartum. Mom was still pumping like 2 to 4 ounces per breast per pumping session. And baby had had the tongue release the day before. And baby transferred 4 ounces in 15 minutes.
Baby was hungry.
So improved breastfeeding efficiency. Hell yeah. And both of her daughters had lip and tongue tie. And she actually in neo council brought that up to the neonatologist. Like, see, like when you get things taken care of quickly and it is the problem, wow.
Yep.
Wow.
Other research that I found for post-surgical outcomes where tongue tie releases improved maternal pain, they improved the infant latch, they often improve reflux, but if reflux can sometimes be its own thing, um, but reflux can also be caused by that tongue tie, and it um, improved the ability to transfer milk, which I think you so eloquently illustrated in your last example.
Yeah. Freaking cool, huh? Like,
Yes.
wow. She's a newer IBCLC. She just sat this year. And she got out of the outpatient after she charted and she called me because I wasn't at work. And she was like, "Oh my gosh, I gotta tell you something." I just saw the coolest thing ever. She was so happy and excited and so thankful. And that dyad is still breastfeeding wonderfully, and mom has zero pain, and baby's eating like a champ.
Awesome.
And it's just
Awesome.
fat,
Awesome.
fat and
Awesome.
happy,
Awesome.
fat and happy baby.
All right. Now, I promised that I would talk about the is it really a tongue tie? Because this is one um, that we have come across many, many times where it's looking like a tongue tie. The baby's acting like it can't move its tongue properly. But is it an issue where some body work can make changes? So there are craniosacral therapists out there that do infants. There's chiropractors that treat um, infants. There are PTs and OTs that and massage therapists that all of us work on infants, and our goal is to just optimize everything. And sometimes the issue might be in the hips in the pelvis. And so, yeah, if you make those body work changes, does that change what's happening at the mouth? And sometimes the answer is absolutely yes.
Oh yeah, we've seen it happen many times. Or even if it is a tongue tie and the family does not have the resources, the financial means to get it released, or people won't release it, or doctors or pediatricians are saying, no, it's not a tongue tie. And, they're having issues, or they just don't want to. Like, they just don't feel like that's something that's worth doing to their infant. Um, Body work can help the oral function improve enough that it compensates to where it buys plenty of time to figure out if it's really going to have a lasting lifelong impact or not.
Yeah, yeah. Another question that we would ask if it is really a tongue tie is does changing positions change the latch? I know you have lots to say on that one.
Oh yeah, laid back breastfeeding position, laid back breastfeeding position, laid back breastfeeding position. Laid back breastfeeding position when babies are prone and not supine. So like prone is, laying forward on their stomach kind of, and then supine is like when they're on their back. Um, the tongue naturally will just kind of fall down and cover that bottom gum ridge. And it also, depending on the shape and the size and positioning of the breast and the baby's ability to open, it will also help the baby open wider and deeper. So if I have a tricky tongue tie, and I'm using this constantly in the hospital because again, the neonatologists aren't going to diagnose, and I'm not a doctor, so I don't get to diagnose. So even if I think there's a tongue tie and there's feeding issues and whatnot, I'm like, let's lay you back, let's put the baby prone, and let's see if that can get us through the next couple of days until we can figure out something else. And sometimes, honestly, the fascia and the tissue and the neurons and muscles all firing in that bigger, better way with the tongue down, I'm like, okay, maybe it's not a tongue tie because this is working. And then what's helpful to know is that sometimes what we do at the beginning or when you're working with a lactation consultant to work on latch and positioning is not forever. The baby shouldn't always only eat in that one position. Okay. Um, and so it's just like a temporary thing until like the baby's mouth grows and can open, like things change very rapidly with infants in lactating diets.
And sometimes they can learn that pattern
Hmm.
in that position and do it
Yes.
a few times, and it can carry over to another position.
Yep. For sure.
All right. So, is the tongue functioning properly? That is another one. So, going into a baby's mouth, putting my pinky in that baby's mouth, am I feeling that undulation happening in the tongue, or am I feeling this pistoning happening? So I know that that tongue isn't doing what it needs to, or is the baby just chopping on my finger when I put my finger in the mouth? So I need to, as a PT, look at how is that tongue functioning, and also I'm looking at, can I get my finger easily into the mouth, because the shoulders are up by the ears and the fists are right in front of their mouth. And yeah, sometimes they're so tight in through the shoulders and the chest that they can't open the mouth properly, or their head is stuck back in a manner that they can't open properly. So if their head's in a position where they can't open the mouth properly, it's going to make it really difficult for that tongue to function properly.
Do you remember Do you remember me coming home one day and getting all excited because I inadvertently, because like once again, I'm not a physical therapist. I don't do myofascial release. I've just worked a lot with Mary Ellen, and I know that I'm not going to hurt a baby if I move and touch in certain ways. And so like I know I'm not going to cause harm and I might help. But like I somehow inadvertently, just by massaging and moving baby's head and neck, released like a tight SEM. And then I went back because there was asymmetry in the ability of the baby's tongue to lift, right? It was only on one side. And then I released it. And then all of a sudden I went back underneath the tongue and it lifted beautifully. And I was like, oh my gosh. I got so excited. I came home. I was like, Mary Ellen, accidentally released something. It was so cool.
There are also hyoid muscles that attach from the hyoid bone back to the neck.
Yes.
So that, if the neck is really tight, then that hyoid, which the tongue muscles attached to, isn't going to be able to move. So it's going to make it difficult for the tongue to move the way it needs to. It's going to be a little bit harder to coordinate swallowing as well. So, yeah, I mean, there's so many reasons why that tongue may not be functioning properly. All right. Are other symptoms or other systems impacting the tongue's posture during feeding? And again, we were just touching on this. So, you know, are the shoulders really tight up by the ears? Is their head stuck up or stuck down or to the side into rotation one way? All of that will impact the ability of that tongue to move properly. But I've also seen rib restrictions, even lower in the ribs, hip restrictions, um, impact what's going on at the head. So you can think about if you were a baby, and even if your low back was tight and mom's trying to put you in this position where your back is hurting, even if it's your low back or your pelvis, and you are forced into that position in order to eat, are you going to want to eat if you're put into a position that's causing you pain, even if it's far away from where your mouth is? So you can think of it that way as well.
So I suffer with digestion issues and also chronic pain. And there are times that no, like as a full grown human being that's been in my body for 45 years, that something will hurt in my body and I won't want to freaking eat because of it. So imagine a baby that, hasn't been on this earth that long and doesn't know its body and doesn't know what the hell is going on. Yeah, it's not gonna want to do it.
Yeah, yeah. So yeah, I mean, if you think of it from a pain perspective, and that baby can't express that, um, that's going to make it difficult for them to eat at that point in time. All right, and I know we've touched on this one. Is there possibly torticollis or other restrictions in the body? And again, yes, 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 yes. That will
Yes.
absolutely um, mimic a tongue tie when it's not a tongue tie. Or
Yeah.
there can be both. Again, two
Uh-huh.
things can be true, as you
Two
like to
things can
say.
be true.
There can be a tongue tie and there can be restrictions. So, getting someone to release all of those restrictions that are impacting the tongue can bring it to a level where, do you really need the tongue tie release? Or, yeah, you still need the tongue tie release.
Though, in my experience clinically working with you and other bodywork providers, if that bodywork was done before the release and then the release happens, and then it's done maybe one or two times after, sometimes not necessary, sometimes is, um, the incidence of reattachment clinically, that in my clinical experience, there's not research, but in my personal experience of doing this for 14 years, it lessens the chance of that reattachment because the tongue will function more optimally faster.
Hmm. Yep, absolutely.
Yeah.
All right, and the last one I have on this list, is it another latching issue? And you had touched on this previously.
Yes.
Overproduction of milk
Yep.
will cause that baby to try to guard. So again,
Oh yeah. So it
breathing,
doesn't drown.
yeah. Um, Reflux can mimic a tongue tie because of that milk and acid coming up. Allergies can be another one that can mimic a tongue tie just because the baby's getting really uncomfortable. They might be allergic to dairy, and mom eats a lot of dairy, and that's in the breast milk. And so those allergies in particular can um, mimic a tongue tie. All righty. So let's look at which professionals should be involved in um, in this assessment and treating. Definitely a lactation consultant. I want them to have an IBCLC to help them with anything that's going on as far as if the baby's feeding, yes, get an
Yes.
IBCLC.
Yeah. If
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 that
there's
baby,
lactation and there's feeding involved, IBCLC every time.
right, right, definitely. If the baby is having trouble coordinating, sucking, swallowing, and breathing,
Yep.
get a speech language pathologist on board because
Yes.
they are the experts in coordinating suck, swallow, breathe.
Yes.
So definitely have a speech language pathologist who is an expert in infant feeding,
Yes.
because one that's pediatric, they may be
Eh,
more geared towards speech, um, but one that's definitely geared toward infant feeding. PT, OT, even massage therapist, craniosacral therapist, chiropractor, somebody who does body work
mhm.
that can help release some of that connective tissue and muscle, and to get that baby uh, functioning optimally, will help them to feed optimally. And then a pediatric dentist or an ENT, depending on where you live, who your specialists are, to do any tongue or lip tie releases that are necessary. All right, so let's look at what treatments are available. There's watchful waiting. So just see if the baby grows out of it. Typically not my favorite being a therapist.
Well, and not just being a therapist, but I feel like you and I both have a passion for early intervention and not having to fix train wrecks way later, because they won't always turn into a wreck, but sometimes they do. And trying to untangle that mess once it's there is so much harder than early intervention. So much
Yeah.
harder than early intervention.
Yeah. I mean, when I see my babies, if I'm seeing them in the first week or two,
Mhm.
chances are I'm only going to need to see them one, maybe two times. If it's a really difficult case, three.
Yep.
Um, for babies that are older, they're, getting past a month, I'm going to need to see them a little bit longer.
Yep.
So the older that baby is, the more times I'm going to need to see that baby. And so, okay, so either watchful waiting, PT, OT, and I'll throw in there again craniosacral therapy, massage, chiropractic, for any sort of manual therapy or body work. Speech language pathologists that are infant feeding trained for feeding strategies. Some are myofunctional therapy specialists
Mhm.
as well. Of course, IBCLC if
Yep.
the baby's eating.
Yeah.
And then the dentist or ENT to actually do any of the tongue tie and lip tie releases. All righty. Um, do you want to touch, because you've worked with speech for feeding far more than I have. Do you want to touch on the alternative feeding tools and myofunctional?
Um, I actually feel like I have limited knowledge and experience about myofunctional therapy. I um I feel like I have some of the skills in my toolbox that I've learned from working very closely with our friend Barbara, who's an infant feeding specialist in SLP. Um, but basically it's playing with the baby's mouth and getting them to do other things that then help them feed better is myofunctional therapy to me. Okay. Um, and like, if the baby can stick their tongue out and go and mimic you, then they're going to be able to lateralize and move their tongue to eat better, right? Because babies need to
Right.
move their tongues around to be able to like move boluses of food and or fluids. They need to be able to move and have range. Alternative feeding tools, in the meantime, cups. Cup feeding is like, the World Health Organization and IBCLCs are trained in teaching how to cup feed and and it's the most sanitary, easiest thing to clean in all of the world. Not, we have sterilizers, we have bottle brushes, we got soap, but like worldwide, some of that's not as available. And so using bottles and different other things where like stuff can get stuck in little crevices that aren't effectively cleaned can be dangerous. Bottle feeding is an alternative feeding tool. It's not, once again, it's not a developmental milestone to take a bottle. Um, and also there's finger feeding with syringes or finger feeding systems or SNSs that can be used. There's also spoon feeding, and that's really helpful and good with colostrum. It's kind of very annoying and quite a bit messier. I like cup feeding better if a baby's way older, or I like using like an SNS system in a finger, and it helps them, feed and slow the feed and like teach them skills too. And then there's something called like I mentioned it earlier, like a honey bear, which is like a straw feeding system. And those are like the main ones that would be used in addition to like in replacement of the breastfeeding or in addition or as an alternative to bottle feeding. There are other specialty feeders, but those are for different situations that aren't tongue tie.
All righty. All righty. So let's summarize everything that we've talked about. Um, I would say that lip and tongue ties are common. They don't all need to be treated.
Yes.
Um, do they actually need a surgical release? Or is it some sort of manual therapy body work going to be helpful for them? Is it something in the body that's impacting that tongue and jaw motion?
Yeah.
Which practitioners should you have involved? Do you have an IBCLC involved? Do you have some sort of therapist involved? Do they need to see a speech language pathologist? Do they need to see that um, ENT or pediatric dentist? And I'm plugging myself here.
Heck yeah, you
Therapists can make a
are.
therapists can make a huge impact, and we're one thing that really hasn't been studied at all in the
Hmm.
research yet. So if anybody's listening to this and they're into research and want to get involved,
Yes.
call either one of us,
Yeah.
and
Oh, heck yeah. Please do. We
we
love
would love to.
research.
Yes, we love research and we'd love to be involved.
Yeah.
Is there anything else you would want to add?
I feel like we did one of the most thorough presentations about the issue. I feel like I pretty much said what I needed to say, and I really enjoyed this. And I feel like whoever's watching this is going to have a nuanced, thorough understanding of the issue.
All right. So we shall wrap it up right here. Thank you for joining us today. And we shall see you next time on the postpartum years. Bye.
Bye.